Too much gala dinner.
Yeah, I think we'll go.
In the case of no show of the chairman, the person with the microphone always is obliged to do the job. Okay, it's even better. So good morning, everybody. When Vipul asked me to speak about the case that makes your heart stop for a minute, I had to admit I have nothing to contribute. As far as I remember, my heart never stopped for a minute. But when I was looking for a little escape, I found cases where the heart stopped for 15 seconds. It was admittedly the heart of the patient, not my heart. But I think it may be of kind of interest. So what I show you is the induced asystole technique for glue injection. I have no conflict of interest in this context, and you are certainly aware that both lipiodol and adenosine are off-label if you use them for this adenosine-supported glue injection. The goal of this adenosine-induced asystole is to control the deposition of glue and to use asystole to better control the polymerizing process. And what you can do is you inject adenosine, and the adenosine has an ultra-short half-life time. It's 10 seconds only. It's a physiologic modulator of blood flow, and the main effect we are using here is that adenosine is blocking the conduction time through the AV node, and it is inducing in high dosage temporary asystole. The pre-procedure thing is, it is what we usually do. I think it's not really necessary. I have never observed any issue with this technique. We do ECG diagnostics before, Doppler. It's certainly a good idea to have an ECG during the procedure itself. And for safety reasons, you should have an external defibrillator in place, and I can say I never used it. The application is very simple. You have a 4 French catheter in front of the right atrium, and the magic number is 36. So while the sense of life is I think 41, the dosage for adenosine is 36. 36 milligram IV in front of the right atrium, and you will achieve 15 to 20 seconds of induced asystole. The 36 is true for all circumstances, no matter if you have an immature newborn, 85 years old fat man, nothing, no difference, just 36 milligram. And we have in the last 8 years, 8 years, we have this 49 case. I do this since many years, and have 10 more years experience with this, and no issue at all. So how it works? You have here the monitor and here the screen, and this is normally not this setting, it's just artificial setting for this purpose. So you observe the ECG curve here. You do some test injection. It's an AVM, not an aneurysm, but it doesn't matter. The principle is pretty much the same. So now you injected the asystole, and you see here the flat line, right? The alarm is going on. You have a flat line. Now you inject your glue. You observe the glue is not wandering distal. It stays on place. Catheter is out. Still flat line. Still flat line. That's the moment when possibly the heart of the anesthesiologist may stop or accelerate or something. Now, spontaneously activity is coming back. And here, in short time, you have normal cardiac activity. This is the setup. You have these pedals. You have a catheter here in front of the right atrium, and you have these pedals for the defibrillator on the thorax. We skip the AVM, and I show you an aneurysm. This is an interesting case. It was a young man. He had a significant criminal report, and he was in police arrest. And for any reason, the policeman said all of a sudden he had a mid-facial trauma. Nobody recognized how this could happen. And 10 days after the facial trauma, all of a sudden he had a spontaneous frontal lobe hemorrhage, And the initial CT showed a normal ACOM, and he had on the second on the diagnostic angiogram, he had this dissecting ACOM aneurysm, which you see here, right? Very fast filling. These dissecting aneurysms are neither good for surgery nor good for coiling. Now we are injecting glue under asystole, taking out the catheter. Aneurysm is gone. Mycotic aneurysm. The same thing. Your goal is to obliterate the aneurysm, and you don't want to have anything beyond the aneurysm. You should give the brain a chance to be supplied by collaterals in order to achieve the occlusion of the aneurysm, and nothing in the afferent artery. You inject glue under asystole, as you see here. It's pretty controlled. You inject, inject, inject. Then it's a good idea to take out the catheter. This is the follow-up injection. You see there's still some filling, right? There's filling of the aneurysm. So you come back and do the same thing. You can do this within 2 minutes, no worries. Now you fill up the aneurysm entirely, take out the catheter. And if you look here, you see the collaterals filling the artery. So we were able to induce asystole as intended in all 49 cases. It allows a very nice, very well-controlled injection of NBCA. You can really see where you are gluing. There's no flow. You have instantaneous, complete arrest of the cerebral circulation. You always have spontaneous return to rhythmic cardiac action. We have seen neither complications related to transvenous passage of glue nor distal arterial embolization, and we have never observed any long-term complications related to this. It takes a little while to make your anesthesiologist comfortable with this, but the patient and yourself shouldn't have any issue. Thank you.
Any questions?
And never forget, 36 milligram.
Oh, hello, yeah. What's the percentage of the glue you injected? 30% or 50%?
Sorry?
Percentage of the glue you diluted with?
One by one. One by one. Equal parts of lipiodol and glue brown.
50%.
Equal parts. I mean, it's probably even better if you have this tantalum. It's probably even better. But I mean, I personally am used to this one by one thing, and it polymerizes instantaneously.
We're using the same thing for giant aneurysms when we want to quickly debulk it and get a hold of the neck and sort of do the clipping.
For clipping, yeah.
Yeah.
So I started this, and when I showed it to my new surgical colleagues, they fall in love with this technique. And it's much better than rapid pacing.
Yes.
So the same question was asked to me, and so I will not speak about the heart arrest of the patient, but about my heart arrest. Not for a minute, huh? So, in my experience, I've got all kinds of complications. All kinds of complications. There are some people who don't have. For me, I faced all kinds of complications, and so, to my opinion, it's how we get our experience. So, This is the case of a patient who's 54 years old, bleeding of this aneurysm. This is a fenestration aneurysm on the basilar artery, so which was coiled by one of my colleagues during the acute phase, and there were no complications. With time, the aneurysm had a recanalization here. And so we decided to treat the aneurysm using a jailing technique by putting a stent and coiling the sac. Here is the material used. So this is the procedure. So you can see the AP and lateral view and the navigation of the microcatheter in order to deploy the stent. So you can see here that it was not so easy to find the exit of the fenestration that you have behind here. So just with the microcatheter, we've got the guide wire inside the superior cerebellar artery here. We placed the microcatheter with the stent. And so this is the second microcatheter which was navigated here. In order to coil the sac. So we have one catheter here inside the superior cerebral artery. So we wanted just to coil with the lateral view, we can see it better. So to put a stent so under jailing to coil. And so here you can see the deployment. This is a Leo Baby 335. And so it was a very long stent, so because the fact that we couldn't catheterize the posterior cerebral artery, so I don't know what's the deal here, but so the stent was too long for me. So during the detachment of the stent, you know that on the Leo there is a small anchor, and so when we were trying to detach this anchor, it moved back. And here you have the Leo which came back just a bit here. So we have a balloon inside, so which was the eclipse balloon. And so we kept coiling the sac here, but the stent was shorter here, so at the level of the neck. We said, okay, we will finish coiling, and afterward, so we will put another stent in a telescopic way. And so here we re-navigate the second microcatheter, just to place the stent. And so you can see here the navigation of the microcatheter here. And we started deploying the second stent. So the second stent is coming. And during the deployment of the stent, you will see it here. So you can see it as well on the unsubtraction. The stent didn't open well on its distal part. So you can see here, it didn't open very well. And so you can see here, so we tried to pull it back. But as you know, they are very low profile stents, so they don't have any radial force. It's, so even if it was a 3 millimeters here of a basilar artery, perhaps we should take something which is about 3.54. But here you can see that the stent was not deploying very well inside, so it was not opening here very well, so we decided to pull it back. And by pulling it back, you will see here, so observe just the step of the procedure. So here, it's still deploying, but you can see the tip of the stent, which is not totally deployed. We tried to resheath it and pull it back. So probably here we were over a strut of the previous stent. And so by pulling back the thing, you see here, by pulling back the thing, everything came back. And now we have this big mass here inside the artery and the basilar one. So we tried the microsnare. We tried the technique with the stent with the microsnare. We tried to go through this mesh of the stent and to catch the guide wire. We tried the balloon. We tried everything, and nothing was happening. So we couldn't catch it because you have a big mass here, and so So you can see here, I don't know. So we tried to come back from the contralateral side and catch it, and it was not possible to catch anything. So we changed the size of the snare and whatever, and nothing could be catched. Here you can see the loop that we made at the beginning, and so second, we tried to come back with the balloon like this, and it was not possible to catch it. So now what should we do? So now when we made the angiogram afterward, we saw this. So just I would like to click at the button here, because otherwise it will start again the thing. So we were trying to get down. You can see the microcatheter, or the guiding catheter, which is coming here. Yes, if you have so here the heart of the patient and the basilar artery of the patient is resting. So what could I do here? Look, so we started to have a stagnation of the basilar artery. Again, the solitaire with the technique with the snare, and it doesn't work. So again and again, nothing could be catched. And here we have an arrest of the basilar artery. So the best solution for me is to preserve one part of the basilar artery with the right vertebral artery by putting a stent. Now, which stent should we put here? So the goal is to get all the mass of the stents close to the wall of the artery, to open the basilar artery and to put a stent. So we cannot use here the self-expandable stents because they don't have any radial force, right? So here we need to navigate a cardiac stent, a stent which is over a balloon, so a balloon expandable stent. So you can see here, this is a Sophia guiding catheter. So we, with the balloon, we bring down a bit more the stents, and so we navigate the stent, which is the Kaname 3.5 by 18. We inflated the Kaname here. We opened the stent. Finally, we established the flow inside the basilar artery. We made the CT scan. There is no bleeding. And afterward, we finished by occluding the vertebral artery. We don't have to miss to occlude the contralateral vertebral artery, which is holding the mass of the stent, in order to avoid the migration, the thromboembolic migration. And you can see here that we reestablished the total perfusion behind. So pulling back the stents and whatever, so it could be a solution, but we have to choose the one which could save the patient. And so for me, it was the only solution that I had to save the basilar artery. Thank you.
You use Atlas. Do you think Atlas would have pushed the coil across?
Atlas stent?
Yeah.
So no, it's a self-expandable stent, my friend. It doesn't have any radial force, so it will be collapsed inside the previous stent. So you need something in with the balloon. So a balloon-mounted stent. So yeah, you need a higher radial force. So the cardiac stents, they don't have a high radial force. So they have a force which is given by the balloon itself. Whatever will be the stent, the radial force is given by the balloon. And so here you need the stent with the balloon, and so in order to plaque everything against the wall of the artery. I will keep you your connector.
Right.
Okay, so I think we had enough of coils, so I'm going to show you some other problems. This is a 61-year-old guy. He was chronic alcoholic. He presented, as you can see, with headaches and diplopia. He had a CT-CTA that showed a partially thrombosed aneurysm, and he had hydrocephalus. So usually if you're going to treat these, some of them, I would get the neurosurgeons to get a shunt or an EVD, and he had an EVD put in. So he then was started aspirin Plavix. I met this guy on the ward, and he was really confident that he wasn't drinking. And you know, all of us who drink a lot, we know we always say we don't drink enough. So clearly, I didn't believe him at all. This is his angiograms. As you can see, this is kind of a big aneurysm here. And I did a catheter angiogram. We had a lot of discussion about what we're going to do. I don't know what other people will do. Like you remember the whole yesterday, we talked about different ways of treating this. And as you can see, there is a big aneurysm. It's quite tall, and you got a big clot surrounding this. So question was, this guy wasn't going to need you can't put a stent on this guy because he's not going to comply. He's going to disappear. So we decided to do it something different, and we decided to treat with an intrasaccular device. So you can see I have, and you'll see when I'll show you some of these devices, but you can see the device here. This is a web, and this is an old double layered web, so you can see the markers, and there is a big device sitting in. And you can see this is the tallest web that you can get, and this is a 11 by 9 web in the aneurysm. And then you can see the stasis at the end of the procedure, and we were pretty pleased. And this is very early days, and we have a paper on this since we have done quite a few cases like these. But you can see this here, the stasis. We were pretty happy, and guess he goes away. This is the angiogram, just shows that. He goes away, and then he comes back with an acute subdural, and this was then treated by the surgeons. Again, we had to stop the Plavix. This was the MR done at that time when he came in, and you can see now that he has got a recurrence of his basilar. So question is, what do? We thought we should retreat this. We decided to retreat it. We brought him for an angiogram, and you guess what's happened? Look at the previous web. The previous web has migrated into the clot. So it's just gone straight into the clot, and as you can see here, this is the web here, and this is the aneurysm. So now what are we going to do? He's alcoholic. He's not going to come back. He can't put him on aspirin Plavix, so we need to find another way. So we decided that we're going to put another web in. So he has got one web which you can see, which is like gone in, and now we decided to put another web here, and I put another web. But I wasn't very sure whether this is going to do the job, and didn't want to put a stent. Didn't have very good arteries, didn't want to put a balloon, so I just coiled it around it. So you can see I've coiled it around, and I got the coils right sitting without a balloon across the aneurysm. And you can see this is the final result. And I thought I did a good job. Hopefully this will stay. But then, as you can see, 3 months down the line, he's come back again. And he has now presented with a subarachnoid hemorrhage, and he's basically not doing very well. Again, the surgeons pushed him. He actually did start improving a bit and then we decided we're going to do an angiogram on him and try and put some more coils in. So you can see now, you got all these webs which are migrated in, and then you can see the coils, and I went in and coiled, but he wasn't going to do well, and he died. So there was a lesson for me in this one, that in a partially thrombosed aneurysm, there is probably no indication for web, and we'll discuss this later. If you are going to treat it, you have to control it and put stents in. I've got time for another short case. This is a lady who I had coiled on the right side. She was very good. She had another paraophthalmic aneurysm on the other side, and we were observing the right side aneurysm, and the question is here, and I'll show you some pictures. What do we do when you have somebody with another aneurysm on the other side? This is the aneurysm on the left side. So you can see there's a paraophthalmic aneurysm here. It's not very big. she was very keen on treatment. So, and these are the coil balls from the other side. The right aneurysm was absolutely fine. So, how many of us would treat that aneurysm? It's less than 7 millimeter, it's incidental. You discuss, there are various options, then we can discuss about the option depending what you want to do. But most of us in my hands now, I would probably, many of us would flow divert this. And if you decide to stand, we have different options here. Again, I could P64, pipeline, surpass. I don't use Derivo, and I've stopped using silk. As you can see the angiograms, and I decided to go for surpass here. You can see she's got a bad arch, and then we kind of got it, thought, okay, well, I'll use a surpass. And as you can see here, you got a catheter, you got a cat-5 across. I managed to get cat-5. I thought I won't get a cat-5 up. I managed to get a cat-5. I got the stent up also, and I was very pleased. And as I was trying to deploy the stent, as you can see, I was trying to deploy the stent here, and guess what happens? The stent comes back. So as soon as I'm coming, now you can see the stent is here. Can you see that? And it's deformed. So now I have a problem. I have very bad access. I have a stent that is come back, and the previous talks, you try everything. I tried everything to get in. I tried to remove the stent, and I couldn't get the stent out. I tried balloons, I tried to snare, I tried different wires, and it just wasn't coming out. The flow fantastically was good. Eventually, I managed to get through the stent, as you can see, and I managed to get a transform balloon, and I inflated the balloon, and I had a vascular colleague by the time who had come in, and I thought it was good, but I wanted to get that perfect result, and that's the mistake that you do many times. And I thought, okay, well, I'll inflate it again, and guess what? I have a rupture. So this is my second inflation with a transform balloon in a lady who's elective aneurysm with a question about 5 to 6 millimeter aneurysm. Probably could have not treated it, and now I have a rupture. You remember, I don't know how many of you have seen Tom Hanks' movie. It's very useful sometimes because he remembers all your career of 15, 20 years get tested in 5 minutes. And this is what was happening. And I luckily had a very co-pilot also, my vascular colleague. What I did was I asked him to puncture on the right side and first see what the cross flow is. Again, I should have done that before. I didn't know that. And as you can see that the rupture was right at the top. So I knew the rupture was here. This balloon was here. I had already inflated the balloon on the other side to control the flow. And then what I did was I initially pushed some coils in and started coiling through the balloon because transform will take coils. But after a couple of coils, it wasn't going. So I had to put under the microcatheter and I coiled the whole artery on this side. I had to make sure that the ICA termination, the flow stays across. And as you can see, there was one loop which came in across, but I thought that might just not be a problem. And I carried on coiling, till and this is a CT that shows hydrocephalus. As usual, you do usual post-op management. You got an EVD put in. Eventually, this is the CT. As you can see, there was some hydrocephalus. And I went to see her a few months later, and she was still in rehab, but she significantly improved after a shunt put in, and she's now MRS2. So again, just a complication of trying to be over-enthusiastic, trying to balloon, made my life miserable. I should have probably gone for a simple stand, got a P64 or something. I think I wouldn't have been in a problem. Thank you. Questions?
To fill with the web case, you said putting the web in the partly thrombosed aneurysm was a bad idea to begin with.
Yes.
And you suggested stenting and probably coiling. What makes you think the outcome would have been different if you did that?
Probably not, and I have a presentation on partially thrombosed aneurysms. These are very difficult things, but I have 2 deaths from putting webs in partially thrombosed aneurysm. We have a paper in AGNR, and I know Liebig has also got a paper where he hasn't had death. But the web is a big device. You put in a clot, and the clot in a partially thrombosed aneurysm can change. If you are on particularly if you are on medications or you're an alcoholic, your clot can change, and that web was undersized. We all have coiled a lot of partially thrombosed aneurysms. You don't see something like that. So I think web is not a good idea in partially thrombosed aneurysms when you can't control the neck.
So, in your case, so this first case, so you know that it's a partially thrombosed aneurysm, right? Either the web or the coils or whatever. If you don't obtain a flow diversion here, so you know that the effect
Yes.
will not be so stable on long term. So here, so whatever, you can use all the new devices to put facing the aneurysm and coiling as we saw yesterday and whatever, it will not get the effect because you don't have any flow diversion. Here you will not put a flow diverter on the tip of the basilar because you have both PCA and so you are afraid for the thalamic arteries or the perforators or whatever. So in this case, my first option will be a Y stenting. So, because first of all, the risk of rupture during coiling is rare, and so with the Y stenting, you flow divert by modifying the arteries. And this is an occasion for me to put the accent on those stents that we are putting inside the artery without obtaining the flow diversion, just to cover the neck or whatever. Here we are putting antiplatelets and whatever, and so for something that we can make with a balloon. But if we want to put a stent inside, it's because we are looking to a flow diversion, not to support the coils inside the sac. Because we have the technique to do it with a balloon, which doesn't need any antiplatelet. So here, in this case, so I will look for a Y stenting just to rectify the arteries and to coil and obtain a long term. Yes, I fully agree with you. The web will not work. The web is nitinol, and the nitinol has a shape memory, and it will come back to its initial size. And even if you put coils and additional coils, if you don't obtain a flow diversion, you will not solve the problem of your patient. And here, if I want to make a Y stenting, I will take a laser cut stent, because a closed cell laser cut stent. Why? Because a laser cut stent is a tube, and this tube will keep rectifying the artery. It's not a braided stent which doesn't have any radial force. So I will try to rectify the artery, and I will do it with the laser cut closed cell stent. So this is the option for me.
No,
So
I totally get it. I think partially thrombosed aneurysms are a beast. It's intrasaccular devices don't work there.
yeah, of course.
They don't work there, and it wasn't the right choice. And I, in my previous practice before the web, I would stent them, Y stent, T stent, half T stent, and I think that is still the solution, or laser cut stent, because before the braided stents, we were enterprising and solitaire on them. So I think, and enterprise solitaire or solitaire works.
All right, that was great. Thanks, Tufel. So, and these are difficult problems and with not so easy solutions. So we'll go on to the next presentation. Dr. Pascal and Dr. Demetrius already presented yesterday, but there was a presentation, a case presented by Dr. Raj Nivas, which we couldn't do, so we'll do it now. And it was a giant aneurysm associated with a stenosis, right? Yeah. Yes. Now, I just said, your tempo starts now.
This is a case where we are faced with a dilemma as to how to approach. So this was in the flow diverter session yesterday, but due to short of time, we are presenting now. So this is a middle-aged lady with left ophthalmoparesis. The interesting thing we note is there's a large giant fusiform aneurysm involving the left cavernous segment, but then we also notice a tight stenosis at the proximal part of the aneurysm. So this is a 2D angiography where we know that there was no collateral flow from the ACOM-PCOM, and also if you notice there is a distal antegrade flow into the distal circulation. which do tell us that there is going to be impaired vasomotor reserve in the distal cerebrovasculature. Okay, so the questions here we had are, the first thing we need to address is what is the cause of the narrowing? The second thing is, can a flow diverter, so we cannot occlude this artery because there's no collateral flow, so we need to reconstruct the artery. So can a flow diverter after balloon angioplasty have enough radial force to keep it open? So that's the second question we are faced with. And at the stenotic segment, there's a real risk that the stent, the flow diverter we are putting in, can funnel down, in which case we may have to retrieve it. So what are the causes for narrowing here? The first thing we thought of was, could this be a wall thrombus? We know that in fusiform aneurysms there can be problems with the intima and the media, and this can predispose to wall thrombus, or it could be a dissecting aneurysm wherein you can have a mural thrombus. Later on, this thrombus can result in a fibrotic band, which can be more stiff, and it may not be able to, we may not be able to open it up. And we also note that there can be some secondary atherosclerotic changes at that area. So, on an expert CT angiography, we noticed that a slight hyperdense area surrounding this sac that was filling with the contrast. And we thought, yes, it could be a thrombus, wall thrombus that is sitting there. So the access was tough, as Dr. Whipple had mentioned about this case earlier, but we did take a neuron max across. The first step we did was to do a balloon angioplasty. And here, at this point, we were not sure whether to use a compliant balloon or a high-pressure balloon. But because we thought it could be, it's a fusiform aneurysm, it can be a dissecting nature, we used a transform, which is an intracranial balloon, compliant balloon, a 415. And on inflation, we noticed that the stenosis was opened up by approximately 50%. Although it was not good, although this was not ideal, we thought this is reasonable enough to go ahead with the flow diverter deployment. So we started off deploying the pipeline. So you see the distal segment that has been deployed. At the stenotic segment, it didn't open up very well. I just wanted to show you the video of the sequence of steps that were involved so that you can sort of appreciate how much the push and pull forces we have. If you see here, you have this 5-French catheter, guiding catheter all the way across. So there's a lot of push and pull. So you try to pull back on the stent and push again to try and open up the stent as much as we can. So this is another video that demonstrates the technique again. We're trying to do our best to open it. And at the end of this, we notice this is what the end result of the deployment was. So if you see there, the stenosis is better, but it is not what we wanted. Still, it is probably around 50% stenosed at that segment. So we were thinking of what next to do. So this is the end result. So this is what we got with all those push and pull. What we noticed was there was no dead space between the stent and the arterial wall, which is important because even after this deployment, if you're going to do a balloon angioplasty or you're going to put a stent in, this was a better configuration than this. So we want to emphasize the technique of push and pull. There are a lot of forces involved, but that allows you to avoid that shoulder between the deployed stent and the arterial wall. So then we took now we were safe, the stent is there, we thought we'll do a balloon angioplasty with a high pressure balloon. We took a cardiac balloon across, and then this was what we got. Still, it was not opening up. Again, the question bears on what was the cause for the narrowing. Was it a wall thrombus? Has it become a fibrotic band there? Then what we decided was we had taken multiple opinions. Call a friend at this point, we discussed with multiple colleagues, and then we decided, yes, this is not a favorable condition. We need to open this further. At this point, we want to use a stent with a good radial force, as Dr. Munay had suggested early on. A stent with a self-expanding stent is not going to happen there, so we need to use a balloon-mounted stent. Again, we wanted to use a balloon-mounted stent. Then we had this issue of whether we need to cross this lesion with this catheter, because we were worried that when we were trying to navigate the balloon-mounted stent, it may sort of hook on to this braid there. So we tried to take the Prowler Select across, And then we have taken the 038 catheter, guiding catheter up, and we are trying to navigate the 05, the 5 French catheter beyond. But however, it would not navigate across. So from this position, what we are trying to do is take the balloon-mounted stent across. We see that there, and we have deployed the stent. It was a 4x12 stent. And this was the final picture that we obtained. And we were quite happy with this. This is the final post-procedure angiography. And this is the expert CT. We notice it is fully expanded, opposed well. Again, the deployment is important. We avoided that dead space between the stent and the arterial wall by the deployment we did. Therefore, this helped because after the balloon angioplasty, there is good wall apposition. That is very important for the aneurysm to heal. And there is good antegrade flow. Remember, I had mentioned earlier on impaired vasomotor reserve, and this is what we saw on the expert CT following the procedure. You note that there is some hyperdense sulcal spaces. Patient was extubated uneventfully, but few hours later developed seizures. And at that time, we did a CT scan. If you notice that there is a lot of sort of edema there in the cortex, and as I had mentioned earlier on, this can be because of hyperperfusion and impaired vasomotor reserve. There is a flow redirection that has occurred. The stenosis has been opened up, and there's an interesting phenomenon called as Wynn-Kissel effect, which I had played this video earlier on. What happens is when the arterial wall is elastic, so let's go to this part. When the arterial wall is elastic, the flow is maintained both during systole and diastole. But if the arterial wall becomes non-expansive, non-elastic, like a rigid wall, what will happen is there will be flow during the systolic phase, but the flow during the diastolic phase is lost because the elastic recoil is not there. So there is flow redirection, and the systolic pressures will go significantly high, and the diastolic pressures will go significantly low, and an increase in pulse pressure will happen, and that again predisposes to a significant increase in risk of hyperperfusion. So, the few questions to the audience. What is the pathogenic mechanism for the narrowing? Is it wall thrombus resulting in a fibrotic band, or is it atherosclerosis? Is pre-FD balloon dilatation adequate? What type of balloon would you use? Would you use an intracranial balloon? Will you use a high pressure balloon? What are the determinants of placing a stent prior to FD? Would you place the balloon mounted stent after the FD placement or before the FD placement? And which would give a better wall apposition? And what would you do if this aneurysm was intracranial? Say, for example, here we got away because it's a cavernous aneurysm, there's no risk of rupture, we are okay with doing all these angioplasties, putting balloon mounted stents. Had it been intracranial, what would you do? And I'm opening the questions to the audience, please. Thank you.
Yeah, so that was the dilemma. In this case, it's fine, but if suppose this is an intracranial aneurysm with a stenosis, how would you go? We haven't done so many cases. So I'd love to have opinion from Shabel, Tofel, Professor Henkes. What would you do? An intracranial one, and what do you do in these cases?
So I will answer for these questions that he asked, right? So first of all, so you had the demonstration by making your angioplasty with the balloon, with the cardiac balloon. So you obtain a nice inflation of the balloon, but when you deflate the balloon, it came back.
Yes.
So usually, so Jean-Raymond described all of this. So this is usually a antimal hyperplasia, which is related to the flow of the sac. So on the proximal part of the artery, you have a antimal hyperplasia, which is so the consistent is like a chewing gum. So you inflate the balloon, you place it against the wall, and so when you deflate, it comes back. And the solution was exactly what you did. So by putting the cardiac stent, and like this, you place all the antima, neo-antima, against the wall of the artery, and like this, you've got the flow. So this is probably not fibrosis, not thrombus, it's neo-antima which is developed, and we can see it usually in such kind of big aneurysm. So for the angioplasty, I will make it as you did after placement of the flow diverter. Why? Because if you have a rupture during the inflation of your balloon, because it's a risk when you are putting a cardiac stent in the brain. So if you have a rupture, the artery is covered by the flow diverter, right? So you will not have a diffusion of the blood at this level. So better to get the artery covered by the flow diverter already before putting the cardiac stent. So what you did is perfect like this. So your last question, what was your last question? Intracranially.
When it's intracranial, then when we were afraid to do strong angioplasties,
So, yeah, so intracranial, so the rule for me is to measure the wall of the artery, the diameter of the artery, and I always inflate the balloon, so I use a stent which is 0.25 millimeters less of the diameter of the artery in order to avoid any rupture, because a big risk, so in some press study, they've got two risks, the risk of the rupture of the artery and the risk of the occlusion of the perforators, right? So for the perforators here, this is the indication. But for the rupture of the artery, my rule is always to undersize the stent by 0.5 millimeters regarding the real diameter of the artery.
I think then we can go on to the next session.